All right, so I'm just going to present some cases on these osteoporotic fractures. I've had a unique sort of bunch of people that came in, I think, during this COVID crisis, because a lot of people are doing their own home repairs, and we're seeing all kinds of interesting patterns that are combinations, I guess, that are a bit unusual for the age group. So you can go ahead, Bridget, and advance the slides. This is a patient who fell backwards off of a step stool, basically taking down Christmas lights. But you can see the magnitude of the injuries. Pretty significant supracondylar humerus fracture, a complex proximal tibia fracture with impaction, and the diastasis of the proximal tibia. And she was on a terrible surgical candidate with multiple comorbidities and tissue paper skin. You know, basically presents, you can see that posterior fragment on the supracondylar fracture that was basically tenting the skin. So our hand was forced and we went to the operating room later in the evening than we prefer for these patterns. So you can go to the next slide. So what we did with this proximal tibia was we actually, in these cases, I accept, if you will, the concept that what I'm trying to do is realign the limb and create stability, more so than I'm emphasizing articular, perfect articular reductions. And so with this particular case, what I was trying to do is maximize or get this lady to a weight-bearing state as soon as possible in the lower extremity, given the fact that she basically has a fracture in the upper extremity that I'm going to have a long time getting her weight-bearing to. So plate fixation in my hands takes about 8 weeks to get these people to an adequate place where they can actually start to ambulate, probably 6 weeks before I really let them transfer without a lot of concern. And so with the nail, I let them do that much quicker, even when the patterns are a little more daunting. And so in this case, I tried to get this lady to the point where we could get her mobilized, and that's the reasoning behind the choice. So the suprapatellar nailing was gave us the opportunity or the option. And we actually, if you look at the traction view on the left-hand side, my left-hand side anyway, we got a reasonable effect with ligament ataxis. And then using 2 large fragment screws, we were able to generate pretty reasonable restoration of the width of the tibial plateau. And then it was simply a nailing at that point with the fortuitous capacity to interlock around the proximal screws. So that made a good option for her tibia. And then we can move on to the next image. Next slide, please. And here we had, again, a lot of comminution in the metaphyseal area. You can see particularly on the lateral side. And of course, the medial side is very narrow and sharp. And so essentially what we tried to do there was, again, minimize the soft tissue disruption, because once you start taking these apart, as we all know, there's multiple small fragments that you really don't see on the X-ray. And you can get a sense of that by looking, I don't get the pointer, but if you look on the fourth film from the right, yeah, right down in that area, you go down just a little bit, you can see the comminution in the just go a little to the lateral side, to the right, or left rather, right there. There you go. And just above that, we can see that where the diaphyseal fragment is kind of fallen into the inside the reduction. But I try not to disturb those soft tissue attachments in these particular fractures, because once my global idea again is to get that alignment back with the minimum amount of dissection. And even though this looks like we're off the bone, again, we had excellent fixation with all of our screws, and we opted not to reposition that medial plate because of the fact that I really worry about stress risers in bone that's of this quality. And the plan at this point was to get her to move right away. So she won't be splinted at the elbow. She won't be splinted at the knee. And start immediate range of motion. Hopefully we can get her weight bearing at the 4-week mark.
Joel, what was your surgical approach on that?
On the humerus?
Yep.
So I make a posterior incision, and then all my soft tissue dissection on this is medial and lateral.
Got it. That's what I thought.
So I don't take the triceps off. I just work through the epicondyles, basically. And then if you want to go up the shaft, of course, you would just split the triceps. In this case, we were able to barely we had the range not to have to do that. Next slide, please. So she had tenderness at the, distal radius. We had the worst C-arm imaging. Of course, it was late at night, complex fractures. We had the worst C-arm imaging you could imagine. And we tried to image the wrist. And if you look closely, which I don't know if you can see on a computer screen, unfortunately, I can barely see it on mine, and we couldn't see it the night that we took the patient. We were in the operating room, but you can see in the, on the right-hand side, there's an obvious distal radius fracture. So we ended up doing traction and splinting, which if normally in the operating room in a patient with this constellation of injuries, I would have fixed that fracture. Given this osteoporotic or osteopenic patient who's going to obviously demand more function, I would not normally fix this fracture under most circumstances. Oh, sorry, can you advance the slides? And you can see it's a pretty typical pattern. Unfortunately, like any good fracture surgeon, we cover everything up with plaster so you can barely tell, but that I'm anticipating dorsal angulation at our next visit, and then we'll discuss what we need to do with it. But it's a non-dominant hand that normally would probably do quite well without internal fixation, even though it would look terrible radiographically. But in this set of circumstances where that hand is going to be really important for weight bearing, it does change your decision making to some extent. This case is fresh, so I don't have any follow-up. Just came in last week. We can move on to the next slide. This is a patient who fell off of his truck last summer. He was trying to catch his bird, and he has end stage. Basically, he's just pre-dialysis patient, brawny degenerative change, skin changes in his distal tibia, diabetes. It's just a terrible surgical candidate. He has a total knee above, this comminuted tibial pilon fracture. And again, difficult decision making because he's a terrible candidate for a plate, which he'd like to use to optimally fix and reduce that fracture under normal circumstances. You can go on, please. But again, we opted to do a tibia nailing with a fibula nail so that we could supplement the fixation, if you will, with the fixation through the syndesmosis. You can see the fracture gap that was left. It's pointed out by the red arrow in that third picture from the right, third X-ray rather. And again, normally I would go in and find those fragments and bring them down, but this wasn't a patient who was, given his comorbidities, a great candidate for that. So we were able to establish reasonable stability of his fracture with basically percutaneous techniques, minimized hypothetically anyway the risk to his total joint as far as the risk of infection being lower for an intramedullary nail. The part that is obviously gives a person angst is when you look at that image on the right and you see where the nail ends up versus the stem. And it's hard to leave a longer nail in because in order to get the nail in, you have to be a little bit lower on the tibia. So you're kind of left with this, hoping that the mechanics of the proximal tibia being what they are going to give you a bit more favor. But we can go on to the next image, please. He's now 5 months out. That arrow is not intentionally drawn into the fracture gap. I'll freely admit that it's there. But what that arrow is demonstrating, you can see the sort of dynamism, if you will. The syndesmotic screw is broken. Both of the AP screws are broken. The medial lateral screw looks like it's intact, and the articular fixation screws are intact. And his nail is, but he has generated a lot of callus and is pain-free and has excellent ankle range of motion. So we've been watching this nail to ensure that we don't get into the ankle joint, but it's provided us, he healed without incident. Basically, you know, no matter what I told him, he was ambulating post-op day 1. And, but overall, I think a pretty good result, at least at this point, for a pretty challenging fracture in someone with really, his major issue was the soft tissue envelope and associated comorbidities. You can go on to the next. Okay, so this is another lady who, she was standing on a ladder that was leaning on steps and fell and fractured her proximal humerus and her ulna, or olecranon rather, and a distal radius fracture all on the same side. And again, you know, you look at all these fractures in sort of in isolation, and you would tend to say, well, you know, this is a person who may do well with non-operative management, given the limitations of the outcomes of proximal humerus internal fixation, and the olecranon will probably do just fine if she's, you know, fragile enough, and there's minimal, you know, relatively minimal displacement actually for some of these people who are not very capable of tolerating surgery. And again, the distal radius, there's lots of data out there that suggests that she'd be, with a reasonable reduction that's held, would be adequately treated with a splint and then a cast. But when you put them all together, you kind of take away someone's independence if you leave all 3 fractures untreated. And so, you can go to the next slide. We chose to treat them all, which is, I think if you're going to treat one in this case, unless you can make somebody absolutely weight bearing by just treating one, you're kind of obligated to give them the best opportunity for early motion. And in my hands, in a situation like this, treating all the fractures in that extremity does create that sort of ability to have the person move. So we let them basically at this point wear a Velcro splint after 1 week post-operatively. And so the wrist becomes mobile and functional. I don't splint these, excuse me, you guys can't see my cursor, but I don't splint the olecranons at all. And obviously the proximal humerus is not going to get splinted, but unfortunately, again, it doesn't convert it to a weight-bearing joint, but it does make it a functional joint for assisting in ADLs. And so the concept again here is take 3 fractures that maybe in isolation you would treat non-operatively, and I feel that the patient is probably better served when they're all together in a single episode, treating them all at once. You can go on to the next slide, please. Is it blank? You can go to the next one. There should be a post-op image of the, okay. Well, anyway, ultimately, there was just basically a proximal humerus slide that showed that that construct holds the implant, holds the fracture. To my facetiously saying, the reduction that I see and don't like is the reduction that I created, because in general, that I don't see much movement with that device. The fractures tend to heal pretty reliably, and I have had a couple of failures early on, but that was mainly, I think, some technical issues that I wasn't getting screws up far enough out to the edge, and I have had one lady who had an issue with AVN, which is, you know, a part of the game. But my overall message in treating these fractures is that in isolation, you treat them one way, but then when you see this pattern or this this scenario where there's multiple fractures in the same extremity or on the same side of the body, if you leave those, if we treat them in ways that we normally would, the person is functionally incapacitated for a very long time. And similarly with the lower extremity, I might accept a reduction that I'm not 100% satisfied with in favor of early weight bearing and minimal skin disruption. So I think that the philosophy of mobility is a more overriding driver in these cases than radiographic, you know, satisfaction, if you will.